before you start going and giving lots of active discussion about change, right? So if I have somebody who says, I'd rather not stop smoking, I'm rather enjoying my smoking, thank you very much. If I wheel out all the pictures of the black lungs and stuff, it's going to fall on deaf ears. I don't want to give them patches. I want to get them more ready. And for OCD, I think the same thing is true. So you don't want to just necessarily paint somebody into a corner and give them an offer they can't refuse. I don't want to do that. They're going to pay for that later. And I think that's especially true in families. You must see this doctor today, or else you can't go to summer camp, or else you'll never go out and see the light of day again. I don't like that, because it sets up the treatment to be adversarial, and it will be. It may be anyway. And then I think that has implications for getting somebody on board. You got to do this when you're ready. You can help people get ready. And this information may help people get ready. Because one of the reasons people aren't ready, they feel like they can't do anything. It can't ever be better, so why should I get my hopes up? That's what the slides coming are going to do. Hopefully get your hopes up. So, with kids, we got a ton of this stuff in adults. I'm not going to belabor it. 25 studies, lots of randomized controlled trials. I want to show you some newer kid stuff to show you what's happened with the tried and true methods in adults as we apply them to younger folks. First off, meds. How do the meds work in kids? To summarize, remember I said about the Y box, the Psi box, the children's version? 0 to 40 scale, kids typically come in the mid-20s, and 16 is considered clinical. So the medication trials, randomized controlled trials for lots of different medicines, all the SRIs, and clomipramine. Clinically meaningful reductions on the Psi box, 6 to 10 point reductions, compared to almost no reduction in placebo. That's one thing you see in OCD for 40 years. If you look at studies, you typically see not a lot of placebo responding in OCD. So if you start out at pretreatment with a 25 and you get fake medicine, you're likely to be a 25 or a 24 or a 23 by the time we're done. In other disorders, there's a lot more placebo responding. We don't know what that means, but it's a pretty consistent finding both from the adult literature and from the kid literature. So, consistently better than placebo, because placebo is doing essentially nothing in most of these studies. That's not true for any individual person on average. Maintenance of gain with continued treatment. If you stay on your meds, typically you can maintain your gains. There's lots of exceptions to that. People sometimes have the experience, unfortunately, of being on a medicine for 15 years. It's working great, and all of a sudden it seems not to be working now. So, and sometimes switching strategies come in there, but they haven't been well studied. The downside of medicine alone is residual impairment is the norm. So if you're starting out at 25, 26 and you're getting an 8-point reduction, you got a 17, 18 or so, you still meet entry criteria for the very study you just came out with. That's enough OCD to still matter for medicine alone. So that's another reason we're thinking about adding other things, augmenting, trying different stuff. Non-responders and dose-limiting side effects. Some people just don't tolerate these things well. Some people are more sensitive to medicines than others, and they can't get up into the therapeutic doses, and then it's harder then to treat them. There's a risk of relapse upon discontinuation of medicine. The faster you discontinue somebody, that's what the research says, the faster you discontinue, the more likely you are to see relapse, but still, there's plenty of evidence for problems coming off medicine, unless you've got the symptoms so low that they're almost negligible, and that's another place CBT can play a role. There's the black box warning regarding suicidal ideation. Anybody know about that? That basically means children and adolescents who are on a serotonin reuptake inhibitor. There's a slightly increased risk of them becoming suicidal. There are no completed suicides in these studies in Britain with depressed kids, but it's enough of a concern where there's more frequent monitoring and more frequent monitoring of suicidal ideation in particular. And I think what that leads us to do is to be more cautious. I think that's good, that we're more cautious in treating kids with medicines. At the same time, I don't think we should swing the pendulum all the way around and say kids can't be on these medicines, because in fact, most kids benefit at least some from these medicines, and sometimes that's the only thing they can find. And so I think it's important to be cautious, but not to overreact to these black box warnings. So, CBT. The kid studies in particular, What you see from the open trials, meaning when they just gave CBT, they didn't ask people to be randomized, they didn't compare it to something else. You typically see all around the world, Australia, where else? The Netherlands, the United States, a number of places it's been done. You see about a 10 to 15 point reduction on the SIBOX, which is pretty good. You typically see maintenance of gain following discontinuation. The downside of CBT, of course, and those of us who do a lot of this work know these, one is it can be stressful. If you think about somebody who, remember that example I gave before about touching the fork? There are a lot of people who say, thank you, but no thank you, in response to those kinds of recommendations. We always build up to those. But at the same time, there are people who might say CBT sounds too hard. There are a lot of people who can't find CBT, which is why one of the, I think the most important news is that there's now some dissemination effort being made here to try to make this thing more readily available. It seems to be helpful. And the fact that I'm talking to mental health professionals is very encouraging. Only 4 completed efficacy studies. One was in the Netherlands, one in Australia, one done, the third one there by our team, and there's one right now that's under review that was done at UCLA. I'll briefly walk you through them. They converge to show us, I think, that the CBT seems to work pretty well in kids with OCD. This is a small study. This is Dehan. You see they're comparing here, they're making a direct comparison of CBT, which was done, in this case, twice weekly. So they saw the kids twice a week, it's ages 10 to 17. And they compared that the twice weekly CBT, compared it to medicine alone, clomipramine, which is a Nafranil, if you've run into that before. What you see is both treatments sort of work. There's no control here, there's no placebo control, so we don't know what would happen to these kids if we gave them fake medicine. There's no combined treatment cell in this study, and it's also a small study, so there's things that it can't answer. But what it seemed to suggest is that kids did quite well. They started out around 23, they end up around 10 at post-treatment. That's pretty encouraging. Remember when I said about 10? You know, here's a brochure, go home, pat the kid on the head, say, give me a buzz in 3 months if things get worse. Pretty good. This is out of Australia. They did an interesting thing. They compared individual to group. And they actually did better with group than most people have. And they did so well with group, in fact, it was comparable to individual. So doing exposure-based treatment in the context of a group of 5 or 6 people with everybody's parents in there, it must have been quite interesting to run that study in terms of complexity. But they did quite well. The orange there is a wait list, so asking people to come back in 6 weeks and see how their OCD was, no change there. But they did quite well at post-treatment. This was published in 2004. This is our study, which we completed. This is the first study of its kind in that we did a comparison of the monotherapies, so CBT alone versus medicine alone. And our medicine was sertraline, which is Zoloft. We compared it to combined treatment and to placebo. So we just finished that thing a couple of years ago. I'll show you what we got. I'll show you what I think it means, and we'll go from there. First off, people hung in there. These studies are not always easy to do. Because people drop out, people don't want to continue. For the most part, people hung in. We had a placebo is on the left. We had about 25% dropout of placebo, which makes sense. You're on medicine. You think it's medicine. You're not sure. It's double blind. Is it medicine? Is it not? But you're not getting better. And some kids, either we dropped them or they dropped out of this trial because of that. But in the other active treatments, people hung in for the most part quite well. Less than 10% drop. So the main finding, I was a little surprised by this one, to be perfectly honest. We got a little more placebo responding than you typically do. That's the blue. Combined treatment, which is orange, did really, really well. This ITT thing means intent to treat, which basically means if somebody drops out, then you carry their last thing forward. It's a very conservative way to look at these data. But basically what we got is we got kids doing combined treatment. So they're getting CBT twice, actually 2 times a week for the first 2 weeks, followed by weekly treatment. So weekly treatment versus, yeah, it was surprising. Weekly treatment versus plus medicine, sertraline. Was better than weekly treatment alone, was better than medicine alone. Medicine alone and CBT alone didn't separate in this study. That's where I got my surprise. But then I got another answer to that. look at is who reached that excellent response criteria. So there you see that the people who responded to CBT actually responded better than the people who responded to MED, which is another way to look at it. So you got 40% of the kids in CBT alone reaching 10 or down. You got 55% of the combined treatment kids reaching 10 or down, which is quite good. About 20% of the kids in sertraline and one kid in placebo, which is interesting. He's on inactive medication and he did quite well. But this gave me a little bit of an answer, and I think I understand this better now. If you look at, this is another way to look at data. So basically looking at if you take out the placebo response, how well do people do? And what you see there is Penn versus Duke. This was Penn, Duke, and Brown, but Brown only in this trial put 8 kids in, so we're really just comparing Penn and Duke. And what we wound up with there was very comparable combined treatment outcomes, and higher is better. So the higher scores on the right there suggest combined treatment worked really well in both places. The medicine, it looked like there was a little bit of a home court advantage for Duke. A little bit better responding in medicine alone at Duke compared to Penn. And more than a little bit of advantage for CBT alone at Penn compared to Duke. If you ask me what I think that's about, I think it's about the approach. And I think that we are, I was the therapist in half of those cases. I was a clinical supervisor on that trial, ran the site for the Penn site. And my feeling is we push. We push. And I don't mean in the way that it's, again, not adversarial, but I set very ambitious goals. If I've got a kid who's got contamination fear, I want him to be able to eat off my floor and not ritualize. Because I think it matters. Because I think if you can do that, then the normative stuff that's going to come up day to day in your cafeteria is going to be a lot easier. I don't ask people to do things I wouldn't do myself. I don't ask people to do things I wouldn't ask my own kids to do or let my own kids do. So I'm not frivolous about risk. At the same time, I think you need to push. And sometimes you need to push past places where other people are comfortable. A lot of kids will say, well, I got 4 friends that wouldn't do that. And I say, well, so do I. But I still think in order for you to get better, we need to push to this. We need to do these practices. And I'm going to try to help you do it. So I'm not adversarial. I'm not aggressive about it. But I set an ambitious goal. And I think that has something to do with what we got. And for therapists, I think that has implications. Cutting the hand washing from 50 times a day to 20 times a day is good. I give kids their props for that. It's not enough. Now let's go, how are we going to cut that in half again? How are we going to cut that in half again? Because I know as long as you're feeding OCD, it's going to keep coming back to bug you. We got to start. Some other studies that have been done, I think, have implications. So are there cognitive behavioral methods that are used to reduce anxiety in general? Yeah. Do they work? Seems like they work in other disorders. And wouldn't it be nice if we didn't have to do these kinds of things? It'd be preferable. These treatments are hard. This is what John Passantini sought to figure out. He compared exposure and response prevention, which is the treatment I was just describing, compared it to relaxation training. Kind of teaching people to chill. Exhale. Calm. So it doesn't involve a lot of exposure. It doesn't involve having to leave your school bag without checking it, those kinds of things, or handing in homework without having gone over it 15 times. It doesn't involve any of that. So how did it work? And the answer is, for the first 8 weeks of the study, it was actually winning. So we were able to calm people down. You were able to reduce some of the kind of overall anxiety. You actually seemed to be doing better than CBT was for the first couple of weeks. You see that relaxation's on the right is in yellow, and the response rate. So 100% response rate means every single person who got the treatment is doing great. So at 8 weeks, you got about almost 30% of the kids in relaxation doing great, as opposed to maybe 13% of the kids in CBT. And CBT, if you think about CBT and how it works, you build up slow. So you're probably not doing the hardest stuff in the beginning. You're kind of getting people used to it. They're still ritualizing. They're struggling with it. They're anxious because you're asking them to do things that are difficult. But then you see, sort of a pretty good second half here. So CBT then separates from relaxation. And whatever you're going to get out of relaxation, you're going to get by the middle of the treatment. You're not going to get enough. And those outcomes tell me that's not enough to feel like relaxation is effective for kids with OCD. I get this question a lot. I think Alan, when he made mention of the fact we have intensive outpatient treatments, that we do. There are inpatient units around the country, and there's a lot of question out there is how frequently do people need to be seen in order to get CBT in the most effective form. The downside of intensive treatment is, if you think about that from a scheduling standpoint for therapists and for patients, you need to come 2 hours a day, 5 days a week for a month. How? What's my boss going to say? I mean, those are legitimate questions people ask. Can we do this less frequently and have a similar result? So those are the studies that are being done, and I'll show you some results. This one we did in 2003. It was published. A comparison of, this is an adult study. So this is intensive treatment is in yellow. Twice weekly treatment, 90-minute sessions each, is in blue, which is still pretty intensive if you think about that. It's not like regular 45-minute once a week. But what you see there basically, and it's the Y box again, so higher is more symptomatic. You see a reduction in post-treatment at the end of both treatments. So when the twice weekly was over and then when the intensive was over, the people in the intensive were doing a little better, actually. But then by the time we looked at follow-up, I think 3.5 months out, they were in the same spot. So that was encouraging, suggesting that we can be more flexible about the regimen. We used to only do intensive. I think in the 70s and 80s, I think it was intensive or nothing. And I'd say right now, these results, plus another similar study that was done, plus this one, this is the kid version of that adult study, much smaller sample. This is only 14 kids, half and half. But again, the intensive versus the weekly, this is only weekly. This is 1 hour a week with kids. And we got no difference. I know there's a study that's about to come out of the University of Florida that basically does the same thing that we did with kids, and they did really well with weekly as well. So for us, it feels like we've got that flexibility, which makes it easier to do. I'd say the clinical caveat is there are some folks who've had weekly and had twice weekly. You just may need something more intensive for a subset of people, maybe whose Y boxes are super high, who've got high depression along with it. So I don't think it works for everybody, but at the same time, I think leaves us with some flexibility about knowing that it doesn't have to be intensive for most. So the medicine question, if my kid's already on medicine, should they stay on it, or is it going to interfere with the treatment? If they're not on medicine, do they have to be on it in order to get better? This is an adult study where it was in our clinic, where basically we did with and without medicine. So adults came in and they weren't on medicine. We gave them intensive CBT. There were some adults who came in that were already on medicine, they were on a stable dose. And we said, stay on your medicine, we'll treat your OCD and see what happens. And you see they start in exactly the same spot when they walk into our door. Now it might be the people who are already on medicine started out more severe. It's an open question. But they wind up in the same place, which is a good place. And you also see a little bit of that two birds with one stone effect I was talking about before with depression. On the right is depression. So basically you're seeing people starting out in similar places and cutting their depression by half after doing CBT that really didn't focus on depression. Same thing in kids. Much smaller study, but same thing. This is John Passantini. Same thing in kids. So it's encouraging. People wonder, though. One of the things that we've been criticized about in all these research studies we've done is how well does this translate to the real world? Because you guys may not really be the real world. That's a legitimate question to ask. And people who come into randomized controlled trials might not be like the people you treat in kind of standard clinical practice. There might be something different about them that makes them more responsive, and so people worry about how generalizable these results are. And what we did here was a study where we compared, on the left, our open treatment. So we do this open clinic for folks with OCD. This is an adult study. We compared our findings to studies around the world which randomized patients to treatment condition, and we found no difference. So we thought, okay, that's an encouraging step. Suggests that it doesn't have to do with just people who go into randomized trials. You can get the same results even outside of that context. But that's only a partial step because it's still our clinic. And so another question that's been raised, asked, and answered, Barbara Rothbaum, Rick Warren, both did the same thing in outpatient clinics. They did less intensive treatment. Warren did once a week with adults. They both got very encouraging outcomes. The problem with that a bit is that Barbara Rothbaum and Rick Warren are also experts in delivering the treatment. So one of the questions we have to know is, it's a dissemination question. Can we teach this treatment to people who don't necessarily live and breathe it every day for 15 years? Can we disseminate this treatment to people who are not the developers of the treatment? Because if we can't do that, then we've got a limit to how much we can offer it. So Robert Valderhaug, he's a psychologist in Norway who visited with us maybe 8 years ago, came and studied with us, and then went home to do his dissertation project in Norway and decided to look at this question. So he did a study in rural mental health clinics staffed by master's level clinicians, and it was supervision of supervisors model. John Passantini was the expert in this trial, and he never talked to the therapist. He only talked to the supervisors of the therapist, because if you think about that from an expense base, it's going to be a lot easier to implement that if he doesn't have to talk to everybody. There are many therapists in this study. So this is their study. It's in press in Behavior Research and Therapy. To underscore this, I want to make a point here. This is a rural mental health setting. It took place here. This is Trondheim. This is the area they were targeting for service. This is the Arctic Circle. Okay? That's truly transportability. And to underscore that a bit more, there you go. That's normal. So this is you cannot accuse them of not having done a transportability study. Beautiful place. And I took my own results here. Oh well, I'll do it verbally. My results from a little kid trial we did in '98 are in yellow, and Robert's results are in blue. They are exactly the same. So the answer is, this is very encouraging. We can actually get this out there with the supervision of supervisors model. I think it sets up the stage for doing this kind of stuff around the country and around the world for the next 10 years. So, giving the rationale. So I've given you all the data. I want to tell you how to talk to, if you're a provider, I want to tell you how to talk to folks about this treatment. And if you're thinking about it yourself or for a family member, I want to try to pitch it more directly and talk about how this works. First off, there's a relationship functionally between obsessions and compulsions. So the external cue, quintessential one, is a public bathroom. This poor guy is worried about touching germs and getting sick. He's got a feared consequence, which is really important clinically to know about. I got some people who say, I touched the toilet and that's enough. I don't have any specific thing I'm worried about, but it feels really awful. And then this leads to a shower until the person feels better. It can lead to hand washing. It can lead to wiping your hands. It can lead to sanitizers and all sorts of things, products that are specifically used to reduce the likelihood of the feared outcome. And I think they're problematic for folks who've got this particular form of OCD. So there's a functional link. Obsession gives rise to anxiety. Compulsion's reduced. And when you don't refrain from compulsions, you don't get to see what would have happened with anxiety. You don't get to see that it would go down on its own. And you also don't get to see that the feared likelihood is unlikely. But the feared outcome is unlikely. So if you wash your hands, you'll never know. If you go back to check your book bag, you'll never know what would happen. And therefore, you keep the fear away. So that's the connection. It's got to be broken. There's another way to put it. This is a study that was done by Isaac Marks in the 70s. Oh well. These are fear ratings before and after doing a ritual on the left. And you see, right? So the person touches the thing they're afraid of, the anxiety goes up. You let them do the hand wash right there in the session, goes back down. Then Marks, what he did was he had them touch the same thing again, a second time, goes back up. And then he asked people to refrain. And in this case, it's the first contact with the most difficult thing. This is 3 hours. But after 3 hours, you wind up back down here. Pretty low ratings of urge to ritualize and discomfort. And if you repeat that process hundreds and hundreds and hundreds of times over and over consistently in every context you can think of, guess what? You're going to see this. You might see that. You're going to see a reduction in how anxious the person gets. You're going to see that whole thing flatten out, and that curve's going to drop faster. That's what the treatment's predicated on. In order to do this treatment, we think people have to be somewhat anxious. We try to do this in a graduated manner. I don't try to overwhelm anybody. I don't try to surprise anybody. But I want them gradually confront the things they're afraid of. Because if they don't do that, then I can't change the thinking. I can't change the cognition. So if I have somebody who's afraid they're going to hit somebody while driving, and that then they're going to be responsible for the death of another human being because they weren't careful enough, we have to drive. We have to drive. Now, I might start driving in a parking lot, an empty one. I might work my way up to, interestingly enough, highways being easier than pedestrian streets typically, because why? No pedestrians, right? So you work your way up gradually. You might have somebody in the car with you to begin with. You might then fade them out. As a therapist, I've been in the car with people doing these practices, and I have a hat that I wear. So when I'm first starting out with a person, I got the hat up, and they get used to driving with another person because I'm the second set of eyes. So they figure if they did hit somebody, I might say something. So it's a little easier. But then what I do, with each 6x of exposure, bring the hat down. Right? So after a while, now the second set of eyes is gone. So you work your way up. And in Philadelphia, the place I always do this is the Italian market. Anybody ever driven through the Italian market? That's the top of my hierarchy. Because you're driving through the Italian market and people don't respect the rules of the road. People walk over your car. They walk under your car. They walk next to your car. They have a fundamental understanding that you're going to be a good driver and you're not going to run me over. And that's where I take people when we're working our way up to the hardest stuff. Often school zones are another place I take people. If you're afraid of hitting somebody, 3 o'clock to 3:15 outside of the local high school is the place, or the local grade school, depending on your fear, will be the place to go. Get the idea? Exposure seems to affect reduction of anxiety. Ritual prevention seems to affect the reduction of rituals, which makes sense. We're encouraging people to cut back on the rituals, giving them specific instructions on how to do that. When you do both, you do better. Bottom line. And a lot of times I've seen people come in and they say they have CBT, and I don't hear anything about a hierarchy. Right? So the therapist was encouraging me to not wash my hands, cut my hand washing from 50 to 30, and I don't hear a word about a hierarchy. Or I hear a lot about a hierarchy. And then I find out that, within 15 minutes after my exposure, I was allowed to wash. Not going to work. It's not a bad interim step. If they feel like, if 15 minutes is better than what they've been doing, it's a good step. But it can't be your end step, because it's not going to work. You're going to strengthen the OCD. So what do you learn from exposure? Anxiety is temporary. Avoidance strengthens fear. I use the pool analogy in the summer. So you get some people who jump into the pool and other people who go one step at a time and enhance their suffering into the cold water. I'm a jumper-inner. My 11-year-old daughter she doesn't listen to me. She just eats step. And I think going that slowly can make this harder. Habituation will happen if you let it. You need exposure for people to habituate. You get used to stuff. And also anxiety in anticipation of doing exposure is usually higher than when you're actually doing it. I get that question a lot. Well, it feels so awful to think about it. Well, let's try it out anyway.